Hello, my name is Claire Willocks. I'm the Clinical Lead for Obstetrics for the Maternity Quality Improvement Collaborative. Welcome to this recording, the purpose of which is to give you a practical guide to using the NHS Scotland's 4-stage approach to the recognition and response to postpartum hemorrhage. We hope you find this to be helpful in understanding this approach. Let's start with a little bit of background. Obstetric hemorrhage remains a significant cause of maternal morbidity and mortality worldwide. The incidence in the UK appears to be increasing. Lessons from confidential inquiries in both 2014 and 2017 highlighted the importance of human factors and that we require advanced planning to mount such a rapid and coordinated response. Both the RCOG and American College advise a staged approach to the recognition and response that includes guidelines for escalation of care and a functioning massive obstetric hemorrhage protocol. It has been demonstrated that protocols for recognising and responding to hemorrhage are associated with improved outcomes, such as decreased use of both blood products and high-level interventions, such as uterine artery embolization and hysterectomy. The Californian Maternal Quality Care Collaborative is a multidisciplinary task force which developed a quality improvement toolkit of best practice and implementation strategies. They launched their obstetric hemorrhage toolkit in 2010 and updated it in 2015, by which time they demonstrated that use of it was associated with an over 50% reduction in maternal mortality. To put their context into perspective, California had more than 500,000 births per year in comparison to Scotland's 60,000. Given the population, the maternal mortality improvement from 15.4 to 7.3 per 100,000 women is quite profound. Hospitals who participated in the collaborative are reporting a 21% reduction in severe maternal morbidity compared to an only 1% in non-participating hospitals. And of this improvement, there is a 70% reduction in the number of blood transfusions administered and less admissions to ICU. Staff also call out the change in culture, proudly talking about their QI efforts as if they were talking about their children's school report cards. You might be familiar with some of their key practice changes, which included ongoing risk assessment at least every shift or handover, introduction of PPH trolley, and testing and implementing quantitative measurement of blood loss. This all sounds very familiar. By their own admission, measurement of blood loss was very much a typical practice of eyeballing loss, which they know now led to an inaccurate measurement by 30 to 60%. Now they're using technology to measure blood loss using blood loss monitors which are interfaced with iPads, allowing a quick weigh. The big change, however, is the use of the toolkit using the 4-stage approach. Obs Cymru, the obstetric bleeding strategy for NHS Wales, has been funded by the Welsh Government. This is a 3-year quality improvement project to reduce severe PPH and morbidity from severe PPH. This is hoped to be achieved by providing a ROTEM machine to assess blood clotting and to guide blood product replacement. Obs Cymru developed their own 4-stage checklist with a similar approach to California, and Scotland was inspired by their approach. In Scotland, how are we doing? We launched the PPH prevention and management bundles at the start of the programme in 2013. And although a lot of time and effort has been involved here, there's still variation in practice, with no improvement in overall rates across Scotland. We invited our colleagues from Obs Cymru to present at the networking event in September 2016, following which there was great enthusiasm for us to develop a similar tool. During the last 18 months, we used quality improvement methodology to develop and test a 4-stage tool which would be suitable for Scotland's context. And following robust testing in 3 pilot hospitals, we launched the tool at the beginning of the year. The aim of the tool is to facilitate a multidisciplinary team approach to the readiness, recognition of and response to postpartum hemorrhage. The objectives of the 4-stage approach are for an overall contemporaneous approach recognising the cumulative effect of bleeding and the need for a coordinated response. Readiness incorporates risk assessment. Recognition is using both cumulative measured blood loss and recognition of the signs of hypervolemia. Response is recognition and treatment according to cause, ongoing measurement of blood loss, assessment of vital signs, blood product replacement, and human factors with critical communication and situational awareness of stages. Critical communication includes calling out blood loss, calling out vital signs, and knowing the responsibilities of each member of the team. It will be a change in practice referring to a stage 1 or stage 2 PPH, but should lead to better coordinated team approach at an earlier stage. Reporting is complete documentation and includes debrief and data collection and DATEX submissions. This is where QI methods can improve responsiveness through reporting and measurement with system learning. It might be of help for you to have a paper copy in front of you as we go through the tool and highlight the key points, so feel free to pause the recording now. What is the 4-stage approach? Stage 0 is the readiness or anticipation for postpartum hemorrhage. This stage is completed for all women giving birth to plan for active management of 3rd stage and any anticipated blood loss. Stage 1 is the recognition of and response to blood loss of more than 500 mL and less than a litre for those who've had an SVD or instrumental delivery. We would expect these women to be clinically stable and have lost up to 15% of their blood volume. The recent American Practice Bulletin revised the definition of PPH to be a litre or beyond. However, we kept the standard definition to 500 mL for vaginal delivery and a litre for cesarean section. Stage 2 is when the woman shows signs of hypervolemia and has bled between 1 to 1.5 litres or approaching 30% of her blood volume. This is a tipping point before she begins to decompensate. And stage 3 is for women with a major obstetric hemorrhage who've bled over 1.5 litres, which is more than 30% of their blood volume. Let's look at the stages in a bit more depth. Stage 0 is the readiness, and this is for all women as they enter hospital to have their baby. We document the most recent haemoglobin here and her most recent weight. Usually this will be the booking weight and maybe the 28-week haemoglobin. If you have a more recent weight or haemoglobin, that would be even more helpful. Readiness incorporates antenatal risk assessment, including appropriate preparation for those with special factors, such as correction of antenatal anemia, including folate and vitamin B12 deficiency, and consideration of intravenous iron for those that remain iron deficient. It includes MDT involvement for placenta previa, regionalization for placenta accreta, as accreta was highlighted in the most recent EMBRACE report as a cause of increased mortality, and preparation for those women who decline the use of blood products, such as Jehovah's Witnesses. Any ongoing antenatal risk factors are carried forward to this stage 0 admission assessment. You'll see that we have included preeclampsia here. This is especially for women with severe PET on MagSalv, as they have an increased tendency to bleed. Document any risk factor by placing an X or a circle at the appropriate box. Moving on to perinatal risk factors. The situation and women's risk can change very quickly as labour progresses. Be alert to this. Document any risk factor by placing an X or a circle at the appropriate box. We then plan active management at 3rd stage according to the risk and unit protocol. Where 2 or more risk factors are present, additional ultrasonics should be considered and IV access should be gained. At this point, it is worth talking about ongoing quantitative measurement of blood loss, which you are aware was included in both PPH prevention and management bundles. It is recommended to measure blood loss at every delivery, not just at the point the woman is noted to bleed. This is where critical language is key, moving from she's tripling or bleeding a bit to this lady has a stage 2 PPH following accurate measurement of blood loss using a structured approach, or she has a stage 3 PPH, and if we have not controlled the bleeding by that stage, we would expect all hands on deck and transfer to theatre. The process for quantitative measurement of blood loss will vary according to whether the woman is in the room, having had a normal delivery or instrumental delivery, unless of course this is a secondary PPH, or whether she's in theatre. In theatre for birth without prior rupture of membranes, as occurs with an elective section, we can subtract the amount of LICR we can expect. This would be approximately 700 ml for normal LICR volume at term, half that for oligohydramnios, and double for polyhydramnios. And you can adjust this for multiple pregnancies. This is where team working, communication and collaboration is important for the process, as we cannot rely on the obstetrician who is concentrating the procedure to call out the volume of LICR after the baby has been born. A designated member of the theatre staff or the midwife can call out the amount in suction to the amount of LICR, and anything beyond that will be measured blood loss. In the room, the standard process will be to discard the ankle pad soaked with LICR at delivery and to measure any blood loss by weighing all drapes and pads after the baby has been born. Oops. Back to stage 0. Completion is following delivery of the baby. If measured blood loss is less than 500 ml, it is documented here and the tool is complete. If the woman has a measured blood loss over 500 ml, her care progresses into stage 1, 2 and 3. Stage 1 is just for women who've had a vaginal delivery, either SVD or instrumental. You may ask, what about women with a caesarean section? 1 is a practical point, as average blood loss of caesarean is just over 500 ml, which means that we would need to add every single woman who'd had a section onto this tool. And this is not our definition of PPH for women who've had a section. The other is that sections are carried out in theatre with immediate availability of anaesthetics, usually senior theatre staff and obstetrician, and these women are being continuously observed and monitored. In stage 1, this is where the woman has lost some blood, and we would expect her physiology to be able to compensate below a litre, although this will depend on her circulating blood volume. Before we move on to a detailed breakdown of stage 1, it's worth talking about percentage blood loss in a little more depth. This table of percentage blood loss illustrates that when a woman has lost 15% of her circulating blood volume, she may not notice any symptoms and her vital signs would be normal. She may have a slight increase in her heart rate to 100 or 110, but this can be very easily overlooked. This is a handy table which came from Embrace 2014 and the RCOG, highlighting that small women have small blood volumes. It's difficult to extrapolate beyond 90 or 100 kilograms as we lose the linear relationship. A 150 kilogram woman does not have a 15-litre blood volume, and unless electronic records highlight this, blood volume in larger women will be blood loss in larger women will be underestimated. In stage 1, a 50 kilogram woman will have lost up to 15% of her blood volume at 750 ml, whereas an 80 kilogram woman will tolerate 1200 ml blood loss until she may show any signs of hypovolemia. The rule of 30 will refer to following stage 2. Now we have an understanding of circulating blood volume and percentage blood loss. Let's go back to stage 1. We need to mobilise help for the members of the team we would expect to be there at each stage. And for stage 1, it would be the midwife in charge. And if she needs further assistance, to document it below. It is important to identify a scribe to record all care. Circle the possible causes and act according to the degree of hemodynamic compromise and control the bleeding. These are the actions we would expect in stage 1. We need to empty the bladder and empty the uterus if we expect uterotonics to work. It's important to keep the mother warm and reassure her, and request better lighting or transfer to theatre if required for any repair. Once the bleeding has stopped and the total measured blood loss is between 500 and 999 ml, the tool is complete. As for any documentation, complete the name of the clinician completing the tool with date, time and location. The post-event checklist should be completed, and I'll explain this further in the recording. Stage 2, we would commence after vaginal delivery and caesarean section if blood loss is more than a litre and less than 1.5 litre. I've spoken about percentage circulating blood volume, but I think it's important to raise it again in stage 2. This is where the rule of 30 comes in. In stage 2, we are approaching 30% of our blood volume. The rule of 30 relates to changes in vital signs when a woman loses 30% of her volume. There is a fall in systolic blood pressure by 30 millimetres of mercury, an increase in heart rate by 30% or by 30 beats per minute. The respiratory rate rises by 30%, and any respiratory rate beyond 20 would be concerning. The hematocrit drops by 30%, and the urine output will drop as renal perfusion is impaired. So for mobilised help, what's the difference in stage 2? Here, you would mobilise obstetrician and anaesthetist and any other staff required. At this stage for cause, we'd be thinking about tone and other causes such as vaginal lacerations, cervical tear, retained placenta, and if cesarean section, trauma from entry, especially following previous cesarean section, an extension of the uterine incision, a broad ligament hematoma, or a posterior uterine tear. We could also think of more rare causes such as uterine inversion, which should be fairly evident, as this may occur after instrumental delivery or after vigorous and uncontrolled cord traction by an inexperienced operator. An amniotic fluid embolism would present with very sudden shock, and it would still be possible to encounter an undiagnosed placenta accreta. The aim in this stage is to respond by correcting the hypovolemia and treat the cause simultaneously. We would give warm crystalloid via rapid infusor and transfuse blood according to her hemodynamic status. Effective teamwork and communication between all members of the team is critical in this stage. We would highlight the time that we reach a litre. As you know, these stages can progress very rapidly, and the aim is to prevent further deterioration. This is where we need to work very closely with our anaesthetic colleagues. One of the key messages from the 2014 MBRACE report was not to rely on a single haemoglobin result or wait for the results of a coagulation screen, but to use bedside testing such as HemoQ, ROTEM, or a venous gas result, and to act on these results to guide fluid and blood product replacement. Balloon tamponade is highlighted here. You may think, for goodness sake, this is only a litre, we encounter this all the time. But if a woman has ongoing bleeding at 500 mils or a litre, the earlier we arrest the hemorrhage, the better her outcome. If you're using a second-line uterotonic and thinking of going to a third, this is the time to consider first-line surgical intervention, which would be insertion of a uterine balloon. It does not need to be inserted in theatre, but for practical purposes, as long as theatre is not occupied, we'll be transferring the woman to theatre and considering a third-line uterotonic, such as Hemobate, Carboprost, or Misoprostol for transfer. But throwing them both in at the same time without thinking of other measures would be, as Einstein said, if you keep on doing the same thing, you'll get the same results. At this stage, we should be preparing for the possibility of major hemorrhage. If the final measure blood loss is between a litre and 1500 mils, this can be documented, sign the tool as complete, and go to the post-event checklist. This was stage 2. We're very used to dealing with these, and the purpose of this tool is that we do not become complacent, especially when there's evidence of ongoing bleeding, as these women can quickly decompensate. If the situation progresses to the stage where a woman has lost greater than 30% of her blood volume and there's ongoing clinical concern, we progress to stage 3. We may find we're in a position to start the tool here after stage 0 if blood loss has been very rapid. This is where we recommend all hands on deck with consideration of transfer to theatre if the woman is still in a delivery room. This will depend on the situation and the availability and expertise of senior staff. We would expect consultant obstetric and anaesthetic involvement and activation of the MOH protocol. The difference in stage 3 mobilised help is to consider, is an MOH call required at this stage? Do we need to call interventional radiology? Document time these calls are requested, and if not applicable, place an NA in the boxes or leave blank. By this stage, we would expect continuous monitoring by the anaesthetist. The woman may need central monitoring with an arterial line or even CVP, and she may require a vasopressor and/or intubation. Repeat blood tests would include coagulation, calcium, electrolytes and gases, with even a venous gas and lactate level. We would consider repeat antibiotics for every 1,500 mL lost and ensure the woman has been kept warm. It is vital to prevent hypothermia and acidosis. As per surgical measures of atony, we're now thinking of insertion of an intrauterine balloon if we haven't already, or if the abdomen is open, either insert a balloon or B-lin suture and repair any extension of the uterine incision. The tables in stage 3 provide a number of interventions to consider, and there's simply an aid memoir guiding clinicians in the possible next steps. The action log is a one-stop section for care such as uterotonics, tranexamic acid, IV fluids and blood products administered, as well as measured blood loss. The rationale for having all these in one area is so teams can have a running total of everything given in one section, which is easy to access. The table you can see is the first part of the action log where use of uterotonics and tranexamic acid is documented. Tranexamic acid in itself may be the game changer. The woman trial results were reported in April 2017 and involved over 20,000 women from 21 countries in 200 participating hospitals. In the latest study published by The Lancet, the investigators combined the results with data from the CRASH-2 trial of 20,000 trauma patients. The analysis of these 40,000 patients shows that immediate treatment with tranexamic acid improved survival after severe PPH by 70%. But the benefit decreased by 10% with every 15 minutes delay up to 3 hours, after which there is no health benefit. The WHO recommendation in October 2017 strongly recommended early use of intravenous tranexamic acid within 3 hours of birth, in addition to standard care for women with clinically diagnosed postpartum hemorrhage following instrumental or cesarean section or normal delivery. Tranexamic acid should be given in all cases of PPH, regardless of whether bleeding is thought to be due to trauma or for other reasons, including uterine atony. We have included this in stage 2, although it could be considered earlier. The second part of the action log is recording fluids. The type of fluids administered with the amount infused can be documented here in place of a fluid chart. Document the time started and completed. The very end column allows adding up all IV fluids, and the total can be called out quickly as desired. Confidential inquiries highlighted the need for blood at 2 rather than 3.5 litres clear fluid if the woman is showing signs of hemodynamic compromise. The second page of the action log is for use of blood products, including FFP and other blood products in addition to packed cells. A 1-to-1 ratio of FFP to red cells is recommended in the presence of continued blood loss and massive hemorrhage. There is a section for quantitative measured blood loss and use of cell salvage if in theatre, for example, with a case of placenta previa. This is a table of blood test results, whether a lab test or bedside test. It can take some time to receive a fibrinogen result, and it is recommended that for women whose fibrinogen is less than 2 at the outset of a PPH, the earlier it is replaced, the better the outcome. Finally, as promised, the post-event checklist. This is not the full PPH post-event checklist. However, it is really important to do an S-bar in the room when a woman has had a major bleed or sign out in theatre to confirm the stage of PPH, drugs given, interventions carried out, use of blood products, and the need for a debrief, both for the woman and her family and the team involved. The post-event monitoring requirements will determine the level of ongoing care, need for blood tests and frequency of monitoring. We all know women who may have had a terrible time and who have been very grateful for the good outcome and for the level of care they received. We all learn from these events, and good care after an event can actually be very healing. This has been quite a speed through the tool and supporting documents. Please do contact us with any questions. This is an exciting time to maximise the opportunity for a coordinated approach to the readiness, recognition of and response to postpartum hemorrhage in Scotland. Thank you for listening.